we did an airway assessment, talked about how to assess for an open airway, identify possibilities that would close an airway, whether it be the tongue, burns, swelling, vomit, etc. So now it is important. You need to maintain an open airway breathing and then circulation. Airway first and breathing. If your airway isn't open, doesn't matter if you're trying to breathe or not, you have no way of getting air in. So airway first and then breathing. So once our airway is clear, then we're going to assess breathing. So when we are assess breathing, we're going to assess the adequacy of the patient's breathing. So what is adequate? Well, it really depends, and I know this is not a clear-cut picture. So we look at what a normal respiratory rate would be on an adult. 12 to 20. 12 to 20 breaths per minute is what we consider normal. But it's not just respiratory rate, we need to worry about tidal volume. So what was tidal volume? Tidal volume is the amount of air taken in each breath. And then you consider minute volume. Now we're not adequately measuring tidal volume. We're not pulling out a spirometer to see how much somebody's actually breathing, but we're just looking in general. Do we see adequate chest rise and fall? And what's the rate? So somebody could be breathing 12 to 20 times per minute, but have shallow volume that would make them ineffective in breathing. And also you have to think in too, what makes them ineffective? Are they awake? Are they unconscious, etc.? Because if there's signs of hypoxia or signs of poor perfusion, then we're going to say that their breathing is ineffective. Now, if somebody is awake, has shallow breathing, and within normal range, is that adequate or is it inadequate? So it's something for us to consider when we are performing our assessment. So you need to focus both on the rate of breathing and the volume with each breath. And also we're looking at these range, anything less than 10, you may need assist ventilation zone. But you need to do your assessment. And it's not a clear-cut answer because there's so many factors there. If we're relying solely on the rate, we're not focusing on tidal volume because somebody's tidal volume may be adequate with a rate of 8. Okay, so versus somebody with an inadequate tidal volume or a rate of 16. So the rate is normal, but the volume would not be. So this is where your assessment comes in. What is adequate and what is inadequate? And some of this takes experience, and we're looking at minute volume. What is minute volume? Minute volume is the amount of air breathed in and out in 1 minute. But again, we can't measure that. We're looking at respiratory rate and tidal volume. Is what they're breathing in adequate? And is their rate adequate? We're looking at rhythmia, a slow respiratory rate, and also looking for tachypnea. Tachypnea is a fast respiratory rate. And then we're looking at adequate tidal volume. Is the tidal volume adequate or inadequate? And I know I keep repeating myself, but this is very important for you to understand. Is what's adequate for the patient, what's inadequate for the patient. You can't, again, just say the rate alone, right? So if the rate alone is one factor, and look at tidal volume, your patient's unresponsive, we're going to say their respiratory rate's inadequate. If their patient is awake with no altered mental status, we'll probably say their respiratory rate and tidal volume is adequate because they're bringing in enough oxygen, or at least for what they need. And if we're solely basing everything off of rate, imagine me, you, whoever's in the stressful incident, or maybe we're running around the building here. At some point, me probably more than others, the time I get through running around the building, what am I doing? So I'm probably bending over. My respiratory rate's increased. My tidal volume is probably decreased because I need to bring more air in and out. But it doesn't mean that I'm my airway status is and respiratory rate is inadequate. You don't want to take that patient with just, yes, my range of my respiratory rate would be out of range, my tidal volume would have been out of range, but it's not means that interventions are present. You have to consider what's going on with the patient. So you don't just automatically grab the bag mask device and start ventilating your patient. A, they're probably not going to let you, and B, or we could be causing more harm because our body knows how much air we need. So in cases like that, if the patient's awake with increased respiratory rate, maybe with increased or decreased tidal volume, let it be just to monitor and assess it. Does not mean there's those reasons for interventions. So tidal volume we talked about is the amount of air moved in and out in one respiration or one ventilation. Minute volume is a function of both respiratory rate and tidal volume. So tidal volume times your respiratory rate is your minute volume. And change in either respiratory rate or tidal volume affects minute volume. So we know that. It may affect it toward the positive or may affect it toward the negative. So our minute volume may increase or decrease associated with minute volume, with respiratory rate or tidal volume. So alveolar ventilation is the amount of air breathed in that reaches the alveoli. Look at this in their anatomy physiology. The air that remains in their airway, up airways, even lower airways, everything except that's made it to the alveoli is considered dead space air. So the only air that's being exchanged is that's made it to the alveoli. So dead space air does not change when tidal volume decreases. So if we're breathing at 800 milliliters tidal volume, and let's say our alveolar volume is 300 milliliters, so we're breathing 800, so we have 500 milliliters tidal volume, or dead space air. Now consider somebody who has decreased tidal volume, somebody who's breathing in at 500 milliliters of tidal volume with each breath. Our dead space air hasn't changed, but what will change is the amount of air that's making it to the alveoli. So if from 800 to 800 tidal volume, we have about 500 dead space air. Somebody so 300 milliliters is alveolar volume, roughly, just for example. Somebody's taking in 500 milliliters of tidal volume. Dead space air hasn't changed, so there's how much is actually making it to the alveoli. So those are factors to consider, and we're looking at tidal volume based off of that, because just because they're breathing doesn't mean that much air is made to the alveoli level.